afternoon, good evening, everyone. It looks like we don't have any more people in our waiting room. And then since this is just a 1-hour webinar, we should get going so that people who come later would join. Yeah. So my name is Ireneous Dasoberi. I'm a senior program manager at the AFREhealth Secretariat in KCMUCo, that is Kwame Nkrumah University of Science and Technology, Ghana, the university that is hosting the Secretariat. So we would like to welcome everybody to this webinar on behalf of AFREhealth leadership. We want to say a very warm welcome to everybody to today's webinar. I would be co-moderating this webinar with Glory. So maybe Glory can also introduce herself briefly and then we pick it up from there.
Yes. So my name is Glory Ibrahim and I'm from Kilimanjaro Christian Medical University College, a medical university in Tanzania. And I'm honored to be moderating the session. You're welcome, everybody. I hope we're going to have a very wonderful session with very fruitful discussion.
Yeah, right. Okay. So before we proceed, we would like to acknowledge the e-learning technical working group of AFREhealth that has put this webinar together for us today. We just like to acknowledge their efforts in bringing us all together on this webinar, and then also to acknowledge the NIH Fogarty's International Center for supporting this webinar. We would encourage everybody to keep their mics on mute and then use the chat box to put in your questions and then comments. After the 3 speakers of the day have spoken, then we'll have some time for discussion. So keep putting your questions through the chat box. We'll monitor that and then get the responses to all questions at the end of the speaking period. So Glory, would you want to introduce our first speaker for the day? Then let them come in.
Are we gonna give a few minutes for the people to join, or we will Miss Heavenlight, and we are happy to introduce her, give her time to introduce herself before she starts her presentation.
Hi everyone, I'm Heavenlight Luzinge from Kilimanjaro Christian Medical University College. I'm the Learning Management System Administrator. Yeah, so I'm going to take you through her topic named, Has e-learning regressed to the learning situation during the COVID time? Let's share my screen. Okay. So,
after me? Okay.
Yes.
At KCMUCo, we faced some challenges before the introduction of e-learning. We had the shortage of faculty. This is due to the increased number of students yearly, but with the unequal number of faculty members. Also, we were using traditional ways of teaching. Also, there's no if the students are getting the materials or if the teachers are provide materials. So we had to introduce to renovate our network infrastructures first. Also, the introduction of e-learning, and e-learning can be defined in multiple ways. But with KCMUCo, we define e-learning as the use of technology to deliver learning and training programs. So as I've said, we had to renovate our network infrastructure. So we have the 2 rooms with computers where we do the examinations online. Also, students use the rooms for the personal studies. So before the COVID-19, we were using 3 platforms, Leo platform, Lecturo, and Moodle. Leo is the primary platform that we use to deliver the medical curriculum. Also communication, we communicate via the Leo platform. Also we hold discussions in the Leo platform. But for the lecture system, it's a video content system. It contains different health-related topics with different questions and different articles. Also, we have the model system, which you normally use it for the examinations. We utilize the Kahoots and screencasts so that we can engage more in the classes. The number of courses before the COVID-19, we had 41 courses that were running in the system. We had 1,239 students who were enrolled in the systems. Also, we had 61 faculty members that were utilizing the system. So on 18th of March in 2020, all universities in Tanzania were mandated in order to contain the spread of pandemic. And KCMUCo was privileged enough to have the ICT investment before, and also the pre-practice of the e-learning activities. So we had to do some just interventions so that we can make sure that teaching and learning can be maintained during the COVID time. So we had to re-engage users in the systems, like diplomas were not so we had to introduce them in the system, because everyone was supposed, the teaching and learning had to continue even if the students were not at the college. So we had to platforms, also the social media, information such as the manuals for the users that were not able to orient them in person to be able to be system. Also, we had to orient system, mostly yet use a Zoom platform. We normally use it as, but this time we had to introduce it as a learning tool so that we can cover up the face-to-face teaching. Also, we had to prepare the coordinated schedule. So due to COVID-19 was interrupted, so we had to prepare the timetable that the medical causes at that time of pandemonium. Also, we had to intensify the use of support system so that we can be able to answer to the challenges that the students or our users face. We used even the class representative. We managed to be added to different WhatsApp groups so that we can be able to support our users. Also, we utilize our ticket system for the support. Also, we needed to do follow-ups. So we had to report to the management, how are the things going, if the teachers are really uploading the materials, if the students really get the materials that the teachers upload, or they're holding discussions or assignments. So we had to do all those follow-ups. So due to all that, we can see the uptake of e-learning platform increased by 15% number of students, also 33% faculty members, and 22% of courses. As you can see, the number increased before and during COVID time for the courses, students, and faculty members. Also, the active users for child utilizing the child system. Also, during the COVID time, we did a survey to measure the perception of the remote learning, and we found faculty members were able to meet their teaching and learning objectives by strength of consensus of 81.5 to be more conducive environment for the online teaching and learning, with strength of consensus of 81.1%. So with all that, we faced some challenges which we took as lesson learned. So increased number of users with an equal number of LMS staff. That was a major challenge because number of users kept increasing, but the number of staff kept constant. Also, there was not enough time for orientation for the faculty members because it was an emergency. So for the new faculty members utilizing the system, were not able to orient them for a longer time. So there was not enough time for orientation. Also, from the survey point of view, students found that faced with the challenge of affording to purchase mobile internet bundles with percentage of 7.4%. Also, a challenge of fear of change and extra workload. Some faculty members were afraid of utilizing technology because they feared like from shifting from face-to-face to online. So it was, they thought that we are adding extra work to them. So, but we had to conquer that. Through all that, so has e-learning really rescued the learning situation at KCMUCo? Yes, it did. With the basic sciences and the clinical sciences, we managed the theory part, whereby the practical part, they had to come and do that after the open of the university. So we learned that the right environment is the key. So if you have prepared the environment, it's easy for you to continue with learning, even if it's remotely. As for us, we had the infrastructure and we had the pre-existing the e-learning practices. So it was easy for us to maintain with teaching and learning. Also, we learned to be more creative, innovative, and flexible, and also to embrace technology. So because of COVID-19, we saw some of researchers mentioned like most of the institutions in Africa want for the remote learning. So we would like to share the strategies that we use to implement the e-learning. So for our case, we knew that we needed a new technology because of the traditional way and the scarcity of backup members. We knew that we needed something so that the teaching and learning could be smooth in our college. We got the support from the institution, then we had to upgrade the infrastructure, then we had to look for the LMS solution. What platform are we going to use, which will be conducive to our environment? Then we had to recruit LMS staff who are going to maintain the system, who are going to do all the orientations. So we had to conduct different orientations that students and faculty are aware of the system, how to utilize it, how to access it. Yeah, also we had to monitor and evaluate all the process so that we can know, are we going in the right direction? Are we really doing what we're supposed to do with through the different survey that we conducted? Also, we had to embrace technology by exploring other systems. So with all that, we were able to implement e-learning at Kilimanjaro Christian Medical University College. Thank you all for listening.
Thank you very much, Heavenlight. We would like to welcome the second speaker, and just to remind you, if you have any question, please put it on the chat box and we'll be discussing it at the end of the presentations. So that's much welcome. Dativa.
Yes, I'm waiting to get to gain control of the presentation. I would like to put the pointer. Okay. Could you please help me make it a full screen? Okay. I am failing to navigate through the presentation. Is it okay if I do it from my side, share my own screen?
You can do that. I think Clara will just...
In our continent, Africa. And as part of my PhD, I've been working towards a solution that can be applied, not to everything, but we have a solution that can be applied to a very complex body of knowledge, that is drug prescribing. Next slide. Could you please move to the next slide? Can you hear me?
Yeah, we can.
Ah, okay.
Yeah.
Yeah.
Yeah, so as you may already know, drug prescribing is a very complex and multidisciplinary skill. It requires the prescriber to take into consideration several factors before they can prescribe medicine to their patient. Like you can see on the screen, the prescriber needs to take into a lot of patient-related factors, such as the pre-existing condition of the patient, the co-existing medication that they're already taking, their gender, and also organ functions such as kidney. They also need to take into consideration the drug factors, such as which combine the new prescribed drugs with the already existing drugs that the patient is already taking. So all this complexity creates room for prescribers to create, to make errors. Next slide, please. Yeah, and here I have some numbers just to give you an example of how these errors affect us. We can see in the UK that every 10th prescription that is made by a fresh graduate contains errors. We see from the US, it costs them 21 billion US dollars annually. And we learned from Germany that patients stay longer in hospitals on average 3 days due to prescribing errors. So research has attributed these factors of prescribing errors, especially for fresh graduates, to faculty shortage, as also Heavenlight pointed out. And also there is limited access to information. And also those people who have information, they encounter a problem of complexity of this broad body of knowledge. And next slide. So next slide, please. So and at this point, that's when we come in with the PharmaFrog app. And with PharmaFrog app, we focus on providing essential information on serious diseases and key drugs based on the current treatment guidelines. We make sure that the information is presented in an understandable way using plain English language, presented in small chunks, and we make this information free of charge via smartphones. But most importantly, we ensure causal connection of this information while we present it in the app. For example, if you see in the screen of the app on the left side, we start with the indications, orange color, what goes wrong. We explain what goes wrong, then how to fix this problem with drugs where necessary, and also cautions, what are the precautions and instructions that we have to take into consideration, and then the effect of the treatment that we are applying to the patient. Next slide, please. So as you may have seen, this is a learning app, and any learning activity profits by following the principles of learning, and this we get from the learning theories. The learning theories help us define how learning takes place and which learning activities to deploy in order to achieve the learning effect. So this is at the core, this is the base of the learning when someone uses PharmaFrog for learning drug prescribing. So our framework is based on 3 learning theories. We have behaviorism, where we use activities that will enable the learner to learn through reinforcements by using rewards and also penalties, among others. And with cognitivism, we apply activities that will help the learners to process the information in a meaningful and memorable way by introducing interactive activities like questions. And with constructivism, we deploy activities that will help the learner to build on their knowledge based on experience or based on linking of concepts. So we use like case scenarios to be able to achieve this. Of course, the mobile affordances also enable us to introduce adaptive learning and to personalize the learning to an individual learner. Next slide, please. At the core of so this is how we structure the content within PharmaFrog. We make sure that we facilitate, the user is able to associate with the content by introducing icons and also colors. Like you can see on the slide on the left, the orange defines or describes what is wrong with the patient, and the green is how we can fix what is wrong with the patient. In the next screen, here we have information about a drug. For example, here we have Ramipril. Ramipril inhibits ACE mechanism, thereby reducing arteriolar resistance, which in turn affects the vasopatency. And this is how we are linking information: a drug, its mechanisms of action, and also we link it to the disease that this drug is treating, for example, like heart failure for Ramipril, and include the dosage. You can see here oral, that that is supposed to be followed while attending to a patient with heart failure or hypertension. Next slide, please. And we ensure that our content is logically placed so that they can be able to connect these concepts that we introduce. At the core, we have questions. These questions are introduced in order to facilitate the interactivity with the content for the learners. We have questions that are based on drugs and diseases, only multiple choice questions, which are auto-generated and auto-assessed. And we provide immediate feedback when a learner answers these questions. We also have some case scenario-based questions. I will explain a bit in detail how we are able to achieve auto-generation of these multiple choice questions. Next slide, please. Yeah, so here is an example of how we generated questions for drugs. So we see that Ramipril affects ACE, reduces activity of ACE. ACE is an enzyme, and by reducing activity of ACE, we reduce the blood volume, thereby affecting the cardiac output. So using this, click next. Using this, we can generate one question. Click next, please. Yeah, this is an example of a question. So you can see with the connection of Ramipril, ACE, and enzyme, we can generate an automatic question that says the Ramipril target ACE belongs to, and then we have questions. So for drug-related questions, we came up with 9 templates, and these keep repeating for every drug, and then we get a big body of, a big collection of questions. So this is one way we generated the automatic questions. Next, please. There are different ways we deployed these questions in our app. One way, which was the main, we think was the most innovative idea, was to intersperse these questions with small knowledge elements within the app, which we call learning units. So you can see on the left, we have the small piece of knowledge, and then this is followed by one or more questions. And if it's either about one drug or a disease. So once you answer all the, or you read all the knowledge elements and answer questions at the end, which is presented on the further right, you receive some feedback, how you performed by learning this question, and the summary of what you learned. Next, please. Yeah, so altogether, we facilitate personalized learning within PharmaFrog. You choose what you want to learn. One, you can go show me, you can look up for information. We have other types of learners who are interested in reading information and then answering questions. So that's where we have knowledge interspersed with questions, and this is accessed via Teach Me. And we have learners who already have knowledge, and they just want to assess what they know, or if they where to start from. For this, we have quizzes, which are a series of 10 questions. But still from series, you can still access the content. If you fail a question, you still have an opportunity to get further information on why it's wrong, why it is right, and you can move around different parts of the app. Also important is that these people don't forget this information. We give them like daily refreshers in form of one question, which they can answer and keep up to date with their knowledge. And this is how we facilitate personalized learning within the PharmaFrog app. Next, please. Yeah, so when the user interacts with the app to look up information or answers questions, they earn some proficiency. So we have a proficiency score, you can see, with different colors and numbers. And this is what we estimate as the prescribing skill that one earns by learning with the PharmaFrog app. But you know why when we learn something, we forget it after a given period of time. So our knowledge declines exponentially with time if we don't do anything to retain this piece of information. So in PharmaFrog also, we apply this, the knowledge or the estimated skill, which is...
Sorry, Dati, can you please be wrapping up for the sake of time?
Okay, 3 minutes, please, if you don't mind. I'm almost coming to an end. So this declines with time due to the normal forgetting effect. And to achieve this, so that you can, next please, so that you can remember the content, we deploy repetitions. And these repetitions are adopted to your individual learning capacity and to the content difficulty. Like you can see on the first graph, a good student will have less repetitions of the content before they can master it. But for a poor student, they will have to repeat the same content most times in order to master it. The same applies to content difficulty. Easy content will have less repetitions, and difficult content will have more repetitions. So this is how we're adopting learning to individual learning capacity and content difficulty. Next, please.
Half a second, please.
Yeah, so we deployed this in Tanzania and we had some feedback. People used the app. We could see they navigated in 2 different areas. Next, please. And we assessed the app for learning effect. Next, please. We assessed the app for learning effect. We noted that through repetitions, there was learning achieved via multiple repetitions. If they answered the question the first time, the second time, the third time, they were more likely to pass this question or answer it correctly. So this brings me to the summary that we have a learning framework based on 3 learning theories. When we applied this framework into PharmaFrog, we noted a learning effect. Next, please. We noted a learning effect, and we think the beneficiaries of this app are medical students and healthcare professionals. This framework is presented in PharmaFrog, but we think it can also be applied to other e-learning or electronically delivered courses, and not only prescribing. Thank you all for listening. This brings me to the end. I will wait for your questions.
Thank you very much, Dativa. That was a very detailed presentation. For the sake of time, I will welcome the 3rd speaker. Please keep on writing your questions on the chat box, and we'll have a discussion at the end of it. Roy, you're very much welcome.
Yeah, thank you. Thank you very much. Can you put up my slides? So I'm Roy Mubuke from Makerere University. Go to the next slide. And what I'm presenting is our experiences of how we've, leveraged e-learning to continue academic activities at Makerere University College of Health Sciences. Next slide. This was just an opener, which is so some brief context of where we were. Makerere University has got an elaborate e-learning policy, which is available. It has been available for actually since 2015. So it is a very rich policy which encourages blended learning. We've got a learning management system. It's a model-based system. So like the first presenter from KCMUCo, we also have a model-based system. We call it the Mwele. We've got institutional support, and we've got structures. We've got an Institute of Open Distance and E-Learning at Makerere, which offers support. We've got electronic databases, and we've got a directorate of IC support. And of course, we've got free, accessible and strong internet on campus. And the faculty that, of course, deliver learning. Next. So that's some bit of context I wanted to bring across. Next slide. However, despite all that, there was a problem. Faculty, especially at the medical school, where I'm based, were not utilizing these platforms, okay? And this was due to, we think it was due to the different pedagogical beliefs. And I've put a quote there. This is a quote from a faculty which I got about last year before the COVID, that e-learning in medical school cannot work. We were never taught that way. So you could see the thinking that was prevailing at that time, despite the support infrastructure around. Next slide. So that was a problem we had. Now COVID-19 came in, we changed the teaching and learning landscape globally, and of course at Makerere as well. So I was interacting with one of our members, and I got a quote down there in blue. Now the mindset had changed. How can we incorporate some aspects of e-learning into reaching out our students during this lockdown? So you can see that previously the perception was actually we cannot do e-learning in the health sciences. Now it is changing to how can we? So those of us who are supporting teaching and learning, we saw this as an entry point, because now faculty had realized the students have been away. How can we reach out to them before it gets worse? So this was our strong entry point to the incorporation of e-learning in the health sciences. Next slide. So we had to devise a way of bringing about the change so that we incorporate e-learning and have a blended learning approach. So we sat down, and when I say we, this is a team of people who are spearheading this to see that approach, so that even doing them in the health sciences disciplines. So we adopted the theory of change model based on the 4D model of appreciative inquiry to bring about the change and introduce some aspects of e-learning into the training of health science students. So this model is basically, I won't go through everything, but many of you I think know it. It's based on identifying the positive core on which you can build through a participatory approach. So in our case, our positive core was that we had strong ICT infrastructure in the institution. We had a learning management system, which was very underutilized. We have IT support right away from the main university campus up to the different actually colleges. They have IT units. So that was our positive core, which was redundant. So the COVID-19 that ain't utilized. So what did we do? Next slide. our first engagement was actually training. So we needed to train faculty, and realize actually many of the faculty didn't know some of these, online platforms. We had to train. Use of the learning system has been in existence for close to 10 years, but many of the faculty in the health sciences, because they were not taught that way and they were not believing in online learning, they didn't know it and they didn't use it. Actually, many of them hadn't even put courses or learning content onto the system. So we had to engage the IT support and the Institute of E-Learning to start rigorous training in the College of Health Sciences of faculty and students on how to use the learning management system. Not only the learning management system, but also other online platforms like Zoom, like Skype, like Microsoft Teams, so that they can reach out to the students. So the training also involved the students into the use of the learning management system, and we engaged the expertise that we had in the university, like I've told you before, as well as the telecom operators to reduce costs, which they willingly accepted. So we have strong internet connectivity. Next slide. So training was our main feature. So in the College of Health Sciences, we've got about 80% of all faculty trained in the use of the learning management system. We have carried out rigorous training sessions, and we've done this via Zoom. And now 80% of faculty have got their courses uploaded as well as content uploaded onto the system. And now they know to navigate through the system, they know how to maneuver through, and now they are beginning to reach out to their students. We've also had them use Zoom to reach out to the students. We've had quite a number of engagements taking place, like students attending tutorials, students attending lectures, postgraduate students presenting their dissertations, and as well as research proposals via Zoom and MS Teams. So this we have somehow succeeded, as now there is a lot of renewed enthusiasm to use a blended learning approach even at the medical school. Next slide. So despite that, we've still had some challenges. So yes, the interest has grown, people have embraced it, but there are challenges. E-learning can never replace bedside teaching or the clinical learning that we know of. We still need that, real interaction between the students and the patients. So this is still a challenge. And like the previous speakers have mentioned, change of mindset change has been very, very crucial. It still persists in some faculty, but slowly I think we are addressing that. And then there are issues of connectivity off campus. There are issues of students not having data. Some students don't even have, gadgets like computers or smartphones. So training is needed for both faculty and students. Much as you have the learning management systems, this is not enough because it will be there and it won't be used, okay? So you need to train faculty. I'm on the last slide, the next slide. You need to train faculty and students on how to navigate through this system, because we've realized it has been there but been idle, okay? Right now, faculty are waking up to realize that actually there is a lot of, a lot of stuff they can do with this learning management system. So they need regular training and continuous, not a one-off training. You need support, resources, and infrastructure from the institutions in terms of ICT support, technical support, as well as reliable connectivity of the internet. We need the right policies to support a blended learning approach, as well as quality monitoring and quality assurance mechanisms to follow up, this kind of blended learning approach online. We need change in attitude of our cannot embrace online learning. We need to keep changing our attitudes. Access to internet is still an issue, especially when students are far off where they need and they don't have smartphones. So we need to engage your stakeholders so we can address this. And lastly, much as we are advocating for online learning, e-learning, it can never replace bedside teaching or clinical teaching in the real environment. So in the health sciences, this is still an issue we have to think about. Much as we advocate for blended learning, we need to find out ways of how we can actually incorporate both physical interaction with the students as well as having online learning activities for the students. So thank you very much. That was my presentation.
Thank you very much, Roy. I think we are done with the presenters, the three of our presenters. Thank you very much, Heavenlight, Dativa, and Roy. That was a very good presentation. So I think we'll have to jump to the questions. So to begin with, we'll begin with Bjorg. She's asking, I'm wondering where the students were accessing their courses, that is from home, internet, caves, and other locations. So if we can have Heavenlight or Roy respond to that before.
Come again?
So we have a question, first question. Bjorg is wondering where the students were accessing their courses from, that is home, internet, caves, or locations. So maybe we can have you and Heavenlight response to that.
Yeah, just a brief one. A good number of our students that we've interacted with, they were accessing from home on their phones, and some had computers at home, and others they would go to internet cafes. So which still provides some challenges with with connectivity and so on. But that's how they were accessing them when they are off campus. Now we have got some who have returned on campus where there is free Wi-Fi and they can access from campus.
Heavenlight, do you have anything to share from Tanzania? How did they access their courses?
So from our case, from the survey that we did, we knew that our students most of them have mobile devices such as laptops and smartphones. So if some of them didn't have the smartphones and laptops, they say like they were asking for their relatives. So they normally use that at their home places to study. So they used home.
Bjorg, is that comfortable with you?
Absolutely. It was just to look at, I guess, some of these inequities and what can be done, and because it's obviously not just the health, but energy can be a challenge. So yeah, just curious to see what the main challenges were.
Oh, okay, thank you. So we have another question. Will the Kilimanjaro institution continue using these forms of e-learning platforms moving forward? For instance, after the pandemic has subsided, the student might still be given the option. So Heavenlight, would you mind responding to that? Will the KCMUCo continue to use these platforms?
So with the Kilimanjaro Christian Medical University, we use the platform since 2011. So since back then, we have been using the system. So we will continue utilizing the system together with those ones who are newly introduced. So we will continue utilizing the system.
Thank you very much. Kudeja, Alexander, are you comfortable with that? The answer
yes.
wants to add on that?
Yes, thank you very much.
You're very much welcome. So another question will go, I cannot recall if it was stated what level of education does the PharmaFrog app target? So Dativa with the PharmaFrog, does it have any level or anybody from the medicine can use the app?
PharmaFrog is designed for different needs. But at university level, we start at university level for medical students, nursing students, and pharmacy students, as well as health professionals. So depending on your knowledge, you have different ways you can access the information. So there is information about basic pharmacology. These are first year students. Then we have clinical pharmacology, which can be for 5th year students and also health professionals. But it applies to pharmacy, nursing, and medical students.
Thank you. So I think you can also share the right spelling on the chat box so that if anybody wants to have the app on the phone, it will be easy.
Oh, thank you. Yeah, it can be accessible in the for Apple, iPhones, and Android. I put in the chat.
Yeah. Okay, we have another one. What kind of activities consisted of training faculty and students to become accustomed to these new platforms? So, Alexander, what did you actually mean on this? What kind of activities, like, what do you mean?
Oh, when you said that faculty were trained or students were trained, I was just wondering what exactly, or maybe an example of how faculty were trained to use these platforms. Were they just told, given the link to maybe Zoom? And I was just wondering how.
Okay, so Roy, would you like to share your experience before the Tanzania share theirs?
The experience specifically about?
Yes, like what content or how did you go with the training to the faculty and students? I hope that's what you meant, Alexander, right?
Yes, that's what I meant.
Actually, the trainer thought putting PowerPoint slides onto the platform, onto the model platform. And it's beyond that, first of all, on how to design content from the learning objectives, to what content, to what electronic activities, what sort of resources. So the training, and then we took them onto the platform itself and demonstrated to them how they can upload a designed online course, because most of them realized actually their courses were not fit to be put online because they lack certain aspects that the model platform was requesting. So we went through all that, and after designing an online course with a detailed content and activities, discussion forums, and so on, then they uploaded that content onto, actually they are now in the process of uploading onto the learning management system. So it was a rigorous training, which also involved, other experts from our Institute of E-Learning and Open Distance Learning.
Okay.
Thank you.
So from KCMUCo, basically the content to students and faculty member maybe was how they can be able to upload the content, how are they going to be able to discuss with the students, how are they going to be able to use different tools that will interact with their student when they're at home. And for students, because they were not around, actually the videos and the manuals were sent on how they can be able to download the materials, how are they going to be able to discuss with their faculty member, ask questions, and using various tools that were there.
Thank you.
You're welcome. We have another, I think this is our last, if not second last. So overall, all the institutions that presented today find that e-learning was more cost-effective compared to the traditional mode of instructions. So Alexander is still concerned. Are we all thinking that e-learning was more effective than the traditional one? If not, were there any insight in terms of cost-saving modes of instructions during the rapid adoption of e-learning during the pandemic? So what do you guys?
Yeah, I think what we should be looking at is not which one is better than the other. I think they supplement each other, especially for the health sciences. There are advantages of e-learning we could leverage on, but it cannot replace the real, clinical teaching. So, of course, it's resource intensive, especially if students who are our main stakeholders cannot, constantly connect to the platform. So I think we should just aim at identifying what activities in the clinical environment, like discussions and so on, can we put online, and what can we teach face-to-face interaction in the real clinical environment. So it's sort of a blended approach, supplement each other.
Okay.
Thank you.
Yes, I also think it's not about the costs, because we cannot compare the cost which comes with the e-learning. So for our case, we also had to purchase some of the Zoom accounts. So that was another cost. So I think it's not the matter, of course, as how Roy has said. Yes, that's in case anybody has anything to add for the sake of time.
So in terms of maybe conducting examinations, I think with e-learning is less costful compared to the traditional one, because traditional you need papers, but here you can just do online. You don't need cost of papers.
I think that's our last question, if I'm not mistaken.
So we still have a couple of questions down.
How did you
get teachers to join and learn? So online teaching is structurally different from class teaching. How did you made it possible for the teachers to join?
Yes, it's different, but in our case at Makerere at the College of Health Sciences, students had been in lockdown for quite a long time, and teachers sort of disconnected with them. So their time came when faculty actually were wondering what's happening with the students. So they realized they can reach out to them online, and that's when actually they came in with a lot of enthusiasm to learn the different digital platforms on how to reach out to the students. And the response was overwhelming, especially from the clinical departments. We've been seeing most of the faculty from clinical departments actually attending these trainings, and they have appreciated, and they have attended all sessions. Imagine organizing a 10-week session and faculty attend consistently for the 10 weeks. So I think they saw it as an opportunity for them to continue reaching out to their students amid
Hello? Possible to make the teachers join, because we had been using that for quite a time. And
so that was my
hello?
I think we have done about 4 minutes past the hour. Maybe if probably we may want to indulge our participants for the next 5 minutes. I think we still have 1 or 2 questions. We can just quickly address that and then and then wrap up, if that is fine with our participants.
Yes.
So Glory, maybe we can just.
I saw a question that can't we just resort like to simulation? And my quick response to that, yes, we do simulation, for, you know, for students to gain skills. But simulation can never replace, you know, interaction with the real patients on the wards, for example. So, like I said earlier, it's just a balanced approach. We leverage on the advantages of each method so that we can, you know, give a good service to our students. So you can use simulation, you can use online activities, but also we need that, you know, practical interaction with the real patients to get a full package for our students.
Thank you very much, Roy. Dativa, I think we'll read one question for you. What was student view about the PharmaFrog app?
I have two questions actually. The students, the uptake was really nice. We had a survey where many people considered it useful and they would apply it in their today learning. These were results from KCMC, IMBEI, and some another university in Tanzania that I got. And also another person has asked what activities can be online based on guiding learning theories. I'm guessing we just wrote learning theories. And I'm thinking that when we are delivering this content of learning the courses online, we need to make sure we try to introduce activities that will engage our learners actively. For example, by introducing quizzes, by giving them rewards, by introducing some gaming, something that will keep the learner interested in continuing to learn within this material, rather than just providing them with recorded videos and assessing them after 3 months or something. So we need to actively engage them and also provide variability. There are different activities you can implement for different types of learners. Others you need individualization and you need to kind of personalize the learning.
Thank you. If I can welcome any participant who would wish to say anything. We have a very good question from Jokania on do we really need to use the e-learning? I think this can be used as a sum up. Do we really need to use the e-learning for medical students, given the fact that they will need to learn on the management of COVID-19? So maybe we can participate and think of that. Do we really need to use e-learning, taking the fact these people need to go to the hospital and they need to know about COVID-19 as part of their health studies? If anybody wants to contribute?
Yeah, I think, yes, they go to the hospital, but you could still extend whatever skills, whatever reflective critical incidents they've got in the hospital, they can still continue discussing, you know, on the online forum, even when they have come from the ward, when they're in their different places of residence and so on. So yes, still there are critical activities you can put on the platform, much as the students go on the ward. And it helps them to reflect upon what they did and then concretize and conceptualize whatever they learned on the ward. Thank you.
Okay.
Before we close, Roy, Ireneous, do you have anything?
Yeah, so I think we have some senior leaders of AFREhealth on the webinar. I see Professor Kambo, and then also the executive director of AFREhealth. Maybe if any one of them wants to say a word, then before we wrap up.
Well, hello.
Hello.
Good morning, good afternoon, good evening, depending on where you are and the time that it is. My name is Georgina, the Executive Director for AFREhealth. I've really enjoyed the webinar. I wish we had more people joining so that they could also learn lessons to improve on what they are doing. E-learning has come to stay, And we need to look at how we can really make use of it, considering the context in which we are, with our internet connectivity challenges all over the various areas that our people find themselves. But I know that the few who participated today will learn the lessons that others have learned and are using those lessons to improve on what they have. And then they will also go and improve on what they have. I wish to encourage us to participate in future webinars that will be happening. Thank you very much to our presenters and our moderators and all those who participated.
Thank you very much, Georgina. It was nice having you in the webinar. And thank you everybody who participated. It's such an opportunity to work with everyone, learn from each other. I hope we're going to participate in the webinars and get to learn more. So our presenters, thank you very much for taking time to do this and share your experiences. Ireneous, back to you.
So thank you, everybody. Wish you a blessed day, and then see you on the next webinar. Look out for AFREhealth webinar announcements, and then we hope to see you. And then thank you to Glory and everybody, all the members of the e-learning technical working group for putting this together.
Thank you.
And have a great day.
Bye-bye, everybody.
Thank you.
Thank you, everyone.
Yeah.
You're welcome.